Hi, I'm Debbie Levine. I'm the Senior Deputy Editor for Radiology, and I'm here today to introduce the April 2016 Radiology Podcasts. The first podcast is for an article entitled Magnetic Resonance Fingerprinting for Rapid Quantitative Abdominal Imaging, and Dr. Kressel and Dr. Gulani have a very interesting conversation about that article. Our next podcast is a bit longer than our typical podcast, but that's because it incorporates two research articles and an editorial. So the first of those two articles is entitled Quantitative Features of Liver Lesions, Lung Lesions, and Renal Stones in Multi-Detector CT Examinations. And that has two authors who are participating in the podcast, Dr. Solomon and Dr. Samai. And then the second research article is dealing with virtual monochromatic images from a dual energy MDCT acquisition, variance in CT numbers. And two authors are participating regarding that paper, and they are Dr. Mileto and Dr. Nelson. And then we have also participating Dr. Fletcher talking about his editorial dealing with uncertainty in CT images. I'm sure you'll find this discussion that Dr. Kressel leads very interesting. So I hope you enjoy our podcasts.
Hi, and this is Herb Kressel, and welcome to this month's Radiology Podcast. Today I'm delighted to be joined by Dr. Vikas Gulani, Associate Professor of Radiology, Biomedical Engineering, and Urology at Case Western Reserve Medical School, and Dr. Gulani is the Director of the MR at Case Western. Welcome, Dr. Gulani.
Thank you. Thank you very much for having me.
Well, I attended last year's ISMRM meeting, and the buzz everywhere was about this new, incredibly interesting technique, MR fingerprinting. And I was delighted to see a paper submitted by you and your group on MR fingerprinting in the abdomen. And I suspect many of the people who are hearing or viewing the podcast may not be familiar with MR fingerprinting. Can you tell us exactly what is MR fingerprinting?
MR fingerprinting is a technology that we developed to provide very accurate and efficient methods for quantifying multiple parameters simultaneously in MRI.
So it's a way of getting rapid quantitative MR data.
Yes.
How does it actually work? It seems very complicated and sort of science fiction-y.
It's a very interesting method. What we do is that instead of modeling our images as some sort of exponential decay or exponential recovery, what we say is, okay, we'll let the signal in MR vary in ways that we would never have tolerated previously. And so we generate very complex looking signal time courses very, very fast. And then what we do is we go back to our knowledge of physics and we build a dictionary of all possible time courses that would have been that we can conceive of based on a possible range of the parameters that we could be measuring. And then once we have this dictionary, we simply match the time course in each pixel to the best corresponding entry in the dictionary. When you match it, the numbers that went into creating that dictionary entry are the numbers that we're after. So for example, T1 or T2. And so with doing this, we end up with very accurate, very fast maps and efficient, and much better than we had ever even hoped to go.
So the parameters that you're varying, are those like TR and TE and?
Yes, we can vary TR, TE, flip angle, basically anything that would have been previously thought of as a user-controlled parameter. This can be varied in an MR fingerprinting sequence.
So with these dictionaries that you've developed, it sounds like theoretically you've covered the range of all possible signal patterns. But is there a benefit to kind of keep adding to data based on knowledge of sort of this is the range for colon liver metastases, for example?
Yeah, so right now, the way that we're building the dictionaries, we're taking a fairly general approach. That is that we say, okay, the T1 could range from a very, very small number to a very large number, and we'll vary the T1s possible through that entire range. And this allows us to stay general. So if you don't encounter unexpected differences in your dictionary. Now, in the future, it should be possible to build dictionaries that are more disease specific, and that is something that we're definitely thinking about.
Good. Now, it sounds sort of, I mentioned it sounds science fiction. How computer intensive is this? Do you need sort of all of the NSA's computers to process this?
Actually, it's surprisingly forgiving on the computing side. So the hard work, the heavy lifting is creating the dictionary. But this is done once, and you save it on your acquisition computer, and then it's there forever. So once you've created this dictionary, the process of matching the patterns, the obtained time courses against the dictionary entries, this is actually very fast. It's a very computationally simple task.
So could I do it on my laptop?
Yeah, you could, actually. It would be a little slower than what we would do on the acquisition computer, but you could do it on your laptop.
And speaking about slower, how long does it take to process the data? In this study that we'll be speaking about, you had sort of 2D data that you were looking at.
Right. Since we have the dictionary stored, it just takes a couple minutes to, per slice.
Okay. Now, getting to your...
Sorry.
Beg your pardon?
I meant a couple minutes for the whole set.
Okay. Now, the paper that we're publishing in Radiology is about applying the technique in the abdomen. And as I read it, apparently in trying to use this technique in the abdomen, the variability in the B1 and B0 magnetic fields caused a problem, presumably because the signal inconsistently varied across the field of view and over time. How did you actually go about solving this problem?
Yeah, so B1 inhomogeneities are a known problem for abdominal imaging, particularly at high fields such as 3T, or I guess nowadays intermediate field at 3T. And so these inhomogeneities we expected to encounter. This was not surprising to us. But when you have this problem, then if you have a signal time course that you're modeling the signal time course without including these B1 inhomogeneities, you know that your signal time courses are not going to correspond to the actual ones that you're going to encounter. So we knew we needed to take care of this. And so the way that we went about taking care of it is we said, okay, we could either build B1 inhomogeneities into every dictionary entry as a variable, or we could simply measure a B1 and then add that to the dictionary for each pixel. Pixel-wise, add that to our matching process. And so that's the approach we took, because we can get a B1 map in 2 seconds. So if we're doing a breath hold of, say, 18 seconds, 2 seconds of that is spent on the B1 mapping, and the rest on the MR fingerprinting acquisitions that we're after.
So very interesting. Could you now tell us sort of specifically about the study that is being published in Radiology? What did you do? What did you find? And how did you actually validate the T1 and T2 values that you've derived?
Right. So what we did can be followed from Figure 2. This is instructive. It shows a flow diagram of the workflow. So what we have as inputs into the dictionary are T1s, T2s, and B1 values, TRs, and flip angles to basically model our entire signal time course. Now, the B1 can be derived from the Bloch-Siegert measurement that we did, right? And so using the Bloch equations and this B1 map, then you have the dictionary plus the B1 map. And then you acquire the signal. This is the signal evolution from the MR fingerprinting experiment. And the signal in each pixel is then matched against this giant dictionary. And then once you have this matching process done, the closest matched signal time course from the dictionary, the T1 and T2 that went into creating that entry is the T1 and T2 that we're after.
Okay.
And those are the properties that we map out, and that's what the technique spits out at the end. So that's figure 2. And if you go to figure 4, this then shows this process in image format. So figure A in or subfigure A in figure 4 is a typical image from an MR fingerprinting experiment. As you can see, it looks pretty bad, and this is not something anyone ever used for any diagnostic purpose. But this is what the images are after. But philosophically, MR fingerprinting says we are not after individual images. We're after the map. So why bother trying to make our images look really pretty? We're after pretty maps. And then in B, you see a Block-Seeger acquired B1 map for this subject. In C, D, and E, you see MR fingerprinting maps that have no B1 correction. And in F, G, and H, you see fingerprinting maps that do have the B1 correction. In I, J, and K, we show the subtraction of these maps. So J, for example, is a subtraction T2 map, and T2 is where we see the maximum error from the B1 inhomogeneities. And you see the B1 inhomogeneity contributions to those maps from the difference image.
I see. So T1 and T2 mapping could potentially be quite useful. I know, for example, in the heart, T1 mapping now is all the rage. What specific avenues of application do you envision in the torso?
Yeah. So I see 2 huge directions that we would like to take this in. One is that we in our group are trying to go after a completely quantitative characterization of lesions. And that is that if I can create, based on quantitative acquisitions, a space that includes T1, T2, diffusion, perfusion quantitatively, so you can have a multi-dimensional space with which to quantitatively characterize lesions. And could that lead to more definitive, less variable characterization of lesions, less dependent on the skill of the reader and more dependent on objective data? So this could go towards identifying types of lesions. The other major direction that we see ourselves going in, a huge direction for us, is the idea of response to treatment. Could you quantitatively, and before seeing size differences, assess response to treatment, again, using a multi-dimensional space? This is sort of a holy grail for imaging in some senses, because we're all used to reading our CT scans that come 2-3 months down the road. And 2-3 months down the road, we're telling them, well, this one got bigger, this one got smaller. And we're not able to give really a proper response as to what is happening biologically in this tissue. And secondly, 2 or 3 months later, the patient has been, if the treatment was unsuccessful, he or she has been going through unnecessary treatment for that long. And could we get to an earlier tailoring of the treatment using quantitative approaches in imaging? That's a big issue for us.
Yeah, very, very, very interesting. Sounds like beam me up Scotty work here. Sort of like very, very spaceship.
Yes.
But in the real world, where are we? Is this ready for prime time? Is this something that I could expect in a software release soon? Or is there a whole bunch of further development before people who are listening and viewing this will be able to use it?
So we are using it quite a bit on our patients on a research basis. We hope that it is ready for prime time very soon. We're working to get it out so that people can use it all out there. And so it's around the corner.
So around the corner in the next year or so, or around the corner?
Yeah, hopefully in the next year or so, but we have to wait and see. These things take some time to iron out.
Yeah, well, I think this is fantastic work. It's kind of certainly a glimpse into the future. I'm delighted that you're able to share the work with us, and thanks so much for sharing your thoughts.
Thank you.
Hi, this is Herb Kressel, and welcome to the April Radiology Podcast. This month we have a rather special panel discussion with the authors of 3 related articles published in the April issue of Radiology. As these came across my desk, I was reminded of a point in my radiology fellowship at UCSF where we were working with the GE company on an early version of a CT scanner, and we were having a lot of problems with clip artifacts, and one of the physicists developed some software that he called RubOut that would effectively remove both the clip and the artifact and give you a pristine image. And everyone was so scared about altering the fidelity of the image that program never saw the light of day. Now we're into very advanced image processing techniques that affect dose reduction and visualization. And people have started looking at the effect on the quantitative fidelity of the underlying information as depicted on CT scans. And so today we're joined by Drs. Sameh and Solomon from Duke. Dr. Sameh is professor of radiology and chief physicist in the Department of Radiology at Duke. And Justin Solomon, we're giving him the benefit of the doubt. He's a PhD graduate student. And Dr. Sameh assures us that by the time the issue is published, he will in fact be Dr. Solomon. So welcome, Dr. Sameh and Solomon.
Nice to be here.
Joining them, also authors on the paper by Drs. Solomon and Sameh, are Drs. Mileto and Nelson from the Department of Radiology at Duke. Dr. Mileto is an imaging research fellow in the abdominal imaging section, and Dr. Renda Nelson, of course, is professor of radiology and vice chair for research at Duke. And rounding out our panel is Dr. J.G. Fletcher, who I asked to kind of look at these papers and try to make some sense of them and give us a rationale of how we might go forward. So let's get into the nitty-gritty here. And I'd like to start with Dr. Sameh. And the paper that you'll be discussing is Quantitative Features of Liver Lesions, Lung Nodules, and Renal Stones in Multi-Detector CT Examinations, Dependency on Radiation Dose and Reconstruction Algorithm. So Dr. Sameh, what was really the rationale for doing this study? Was this a matter of sort of theoretical concerns, or was there a practical clinical issue that had been raised?
It's rather a practical one. Actually, it builds upon the experience that you relayed to us earlier. As I look at the CT, one of the major hallmarks of the CT has been the fact that it is somewhat quantitative and very precise compared to a lot of other imaging modality that we have out there. At the same time, we do recognize that there are a great deal of quantitative information that can be extracted from medical images. And in the case of CT, of course, the precision of the CT would be of tremendous value in that regard. However, in your experience, you relate to the fact that we have had concerns in the past that we don't want to alter the appearance of the images because we are concerned that that might impact the precision and reliability of the quantitative information that we gain from the CT images. In the last few years, we have seen significant changes in CT. Two major developments have been the development of iterative reconstructions, which aim to provide a more high-quality rendition of CT images. At the same time, there have been a great push to reduce radiation dose. So we ask ourselves the question, if we move into those directions to implement iterative reconstructions clinically and to reduce radiation dose aggressively, what would be the impact of that in the precision of the images that we're going to be expecting from CT, especially in the context of biomarkers? And when we talk about biomarkers, we should also ask the question, what biomarkers? There is not only one biomarker. So we essentially set to look at a series of biomarkers related to the morphology and the texture and the attenuation attributes of lesions of interest in lungs, in kidney, and liver, and to see how those attributes are reflected differently as we change to iterative reconstructions and as we reduce radiation dose.
I see. Thank you. Dr. Nelson, now the study that you all did, virtual monochromatic images from a dual energy MDCT acquisition, variance in CT numbers from the same lesion between single source, projection-based, and dual-sourced, image-based implementations, looked at the specific issue of CT numbers and the monochromatic images that can be derived. So you chose to do a phantom study, and what was kind of the rationale for looking at this and looking at it that way?
Well, we began to see that because we had both platforms in our system, and we realized that the technology is so widely disparate. One uses two X-ray tubes at two different KVPs, both polychromatic, although one is filtered with a tin filter to reduce the lower energy photons, compared to the other platform, which switches the kilovoltage with a polychromatic beam every half a milliseconds. Because the technology is so different, we really didn't have any idea whether quantitation made sense if the differences were not really, were minimal. So we were concerned that before we could really take the next step, say anything quantitatively about this platform, that we needed to do something very, very simple. We chose a phantom study because we didn't want to get too complicated. And we've seen in patients, however, for instance, looking at either simple renal cysts or hemorrhagic cysts, that there are a lot of differences from patient to patient. So differences in size of the patient, differences in other beam hardening characteristics. So we chose this phantom because it was simple and we could make some meaningful conclusions from doing that.
Now, the monochromatic reconstructions, I think people, listening and watching this would kind of like to know, what's the benefit of this anyway? Why is it worth doing?
Well, I mean, the real benefit of using virtual monochromatic imaging from a dual energy and DCT acquisition is that you can really select a single photon KV energy. So basically you're not penalized by the fact that you're averaging the energy of your X-ray beam. So basically you're not impacted by energy shift or beam hardening phenomena. But at the same time, you can go down in the KV scale and you can increase your contribution from the image because of the IDEN. But at the same time, you can go upper in your KV scale and you can reduce the contribution of some artifacts. So, but basically there is another important fact we believe is that beyond beyond being inherently different, these two imaging platforms, there are also like some important differences in the approach that the two most readily available vendors use for synthesizing virtual monochromatic imaging. The single source implementation use a raw database approach because during the gantry revolution, basically we have a single tube and the low and high energy quanta are acquired at the same projection angle. By comparison, by using a dual source CT implementation, there is always an inherent like 90-95 phase difference between the low and high energy quanta. And so we are required to use an image-based approach.
Okay. And I gather with these monochromatic reconstructions, monochromatic data sets, you can characterize certain composition as well?
Well, I mean, monochromatic imaging just reflect the Hansfield like scale. So
yes.
So basically, we cannot quantify, for example, in milligrams of iodine per milliliter, but they reflect the CT number scale that we would call like a monochromatic CT number entity.
Okay, very good. So soon to be Dr. Solomon, tell us about your study and what you did and what are some of the key findings?
We had this nice database of images of patients that had known lesions, 3 different lesion types we looked at: liver lesions, lung nodules, and kidney stones. And we had the images at 2 dose levels, 100% dose and 50% dose, compared to standard clinical dose. And then 3 different reconstruction algorithms, traditional FBP and the Acer reconstruction algorithm, and model-based iterative reconstruction as well, MBIR. And so we took all these known lesions, we took the images, and we did a series of quantitative assessments on them. So we extracted a total of 23 different quantitative features, and we drew upon the kind of the radiomics literature to decide what features we wanted to look at. They described things like the size and the shape, the attenuation, the edge blurring properties, the distribution of pixel values, and the texture features. And so we extracted all of those features, and we did some statistical analysis to look at how reducing radiation dose or changing the reconstruction algorithm affected those quantities. And essentially, so we were kind of overwhelmed with the number of different results we had. There was a lot of stuff going on in the paper. But to kind of summarize, we found that both dose and reconstruction algorithm affected the quantitative measurements of various different features. But overall, kind of the largest effect we saw was from MBIR, affected the greatest number of different features.
Okay. So what was some of the magnitude in the differences in the size of lung nodules, renal stones, or CT number or texture differences? Give us an idea of the sort of scale of these changes.
Sure. So, for example, we saw that with lung nodules and renal stones, they were about, the volumes, for example, were on the order of 10% lower when you used MBIR versus filter back projection. When we looked at the texture features, there was kind of a wide range on how they were impacted, but on the order of kind of 15 to 30% differences depending on what reconstruction algorithm you use.
Those seem like pretty sizable differences. They're not sort of in the noise, I would say. In this case, I guess they were in the noise, but in conventional parlance, not it. Anyway, what were some of the key findings of your study, Dr. Mulatto?
Well, basically, we applied a multivariate regression analysis to our data, both polychromatic and monochromatic. And basically, we saw that with changing variable, with the same changing variable under the same condition, basically, so the 2 scanners were responded like in a different way when they were operating in single energy or in dual energy modes. Of note, when the 2 scanners were operating in a single energy polychromatic based mode, what was happening is that, of course, there were differences between the 2 scanners as a function of the iodine content, or for example, the KVP. But when we associated like this variable to the scanner type, basically there was no significant effect of this variable on the differences in polychromatic CT number between the 2 scanners. As opposed to that, With monochromatic imaging, we saw that when we were changing the same variable with different scanner, that scanner were responding like differently to the changing variable. Of note, we saw that there was a 30% differences in monochromatic CD numbers as a function of the iodine content and the energy level. And in particular, these changes were most pronounced at low KV and with the lower iodine concentration investigated, which was 0.8 milligrams of iodine per milliliter in our study.
Dr. Nelson, were you surprised?
Well, I expected to be some differences, but it was more than I expected. And it's a tough issue because, as you know, and JG knows, I really believe that to a certain extent, interpretation of CT is an art more than a science. And but maybe it's less of a science than I'd like to believe. I don't know. I'm struggling with that.
You know, I don't know if you saw, but we recently published a special report. I can't remember the exact title, but it was something like CT images are more than images, they're data. And it was the whole idea of the omics revolution and kind of looking at these features. And then if these features are evanescent, they're sort of data minus, it seems like. Dr. Fletcher, with all of this in mind, I called upon you, a rational mind from the Mayo Clinic who has sort of thought and written about these issues quite a bit. And I thought that the editorial you did with your colleagues at Mayo was wonderful. So how should we make sense of this?
Well, you know, I was on a scanner this morning, and the first two cases are always outside cases. And they look a lot different than what I'm used to looking at. And we've known for a long time that CT number isn't some truth. It's really dependent on the X-ray spectra, the detector, the patient. If you do a CT scan on a different system, it's going to look different. And so, you know, as I've looked at these things, I've kind of thought, well, there's two aspects. There's the visual interpretation that I'm doing, and then there's the quantitative aspect, which Dr. Solomon and Sameh did. And, you know, when I'm looking at a scan for the first time, my main job is to detect what's abnormal. And so I really want to do whatever I can to maximize the detection of that abnormality. Now, that might be low KV imaging, it might be dual energy imaging. I'm aware that the images look a little different when I use iterative reconstruction or when I get a monochromatic image. But if I can only give a small amount of contrast, for example, or if I'm looking at a hyperattenuating lesion like an HCC, I'm going to use everything in my arsenal. I'm not going to worry about, you know, because the patient hasn't been imaged before. I'm going to use whatever I can at the moment. Now, you know, I think that when you get into follow-up scans, you know, then you do want to try to use the same technology, or, you know, if you did a multi-phase scan and you're going to want to try to do the same type of scan. We do that in clinical practice. But I think that there is a divergence when we get to using iterative reconstruction in terms of those quantitative parameters that people need to be aware of, and that you know, if you look at, for example, the paper by Dr. Solomon and Sameh, that there wasn't so much textural features that were changing when they kept the filtered back projection at the lower dose. And so I think that over time there is going to be more of a divergence between what we need to look at visually so that we can see the difference versus what we would look at textually, where the textural features are actually teaching us something that we cannot perceive.
But there is this interface where you're measuring a lung nodule over time, someone with a screening CT, and they come to you and you have to measure the lung lesion. And, you know, people are already struggling to figure out how much of a change is a real change. Or with adrenal lesions, you're looking at, you know, CT number changes all the time. So Yeah, I think you're right. I mean, I love the way you conceptualize it, but there's already more of an interface between the quantitative and the morphologic, I think. Doctors Nelson and Mileto, where do you think we are with this? How are you going to use this information in your own practice?
Well, I mean, that's a very tough question. I mean, for sure, I think radiologists, I mean, especially radiologists who are really interested to join a dual energy MDCT program should watch out when they look at the same lesion in longitudinal study with different platform. Because, I mean, we believe that these differences that might be due to differences in the CT equipment might be deceivingly attributed to changes in the tumor biology. And, I mean, for example, in renal lesion imaging, where, I mean, the radiology are accustomed to use CT images with some defined threshold, that might be a problem.
Yeah. So, Dr. Nelson, I mean, I'm not sure, but I suspect that there are people who will be watching and listening to this who already have a dual energy CT, or they have a single energy monochromatic capability, and it's in a department that has other scanners that don't have that. And I bet that's the case at your institution. How are you planning on doing your work?
Well, I think first of all, I think the changes that represent size are probably more important to me. I think we rely more on size reproducibility than we do on attenuation reproducibility. We assume that there are going to be differences. And most of the time when we look at something's attenuation, we're not really comparing to its attenuation previously. We're looking more at its attenuation relative to a pre-contrast or something like that. I think we generally don't rely on those differences from different time points as much because we haven't been able to over the years. So I don't know if that will really change. I'm more bothered by the fact that there's differences in size relative to what Dr. Semay and Dr. Solomon found.
So, Dr. Semay, what do you think we should be doing with this? Are we in a spiral that we're not going to get out of, or is there some way to think about this so that we can have a bit more consistency?
Well, this is an enlightening discussion. I'm very happy that we're doing this. To me, I think there are two ways to take this. One would be taking more of a prospective approach, and the other one is taking more of a retrospective approach. By prospectively, I'm talking about how we can adjust the way we do patient imaging so that we can take more of a quantitative information, more relevant and consistent quantitative information from patient images. And in that regard, I think we need to, first of all, realize as we adjust various attributes of image acquisition, such as dose, we need to realize what is at stake, what is we are potentially compromising in that regard, number one. And number two, where we should put our priorities. For example, I was surprised by the fact that the impact of reconstruction on the features that we were extracting from the images was larger than the impact of dose. I would have expected the other way. Yeah. So if we are putting our priorities, our interests, our funding, our attention toward dose optimization, perhaps a larger fraction of that priorities should also be given to other attributes. That's more of a sort of prospectively adjusting things to make it better. But the other way to also take this on is to think about retrospectively what we can do. Now, we have already acquired images with whatever protocol they have been acquired. What are we going to do? If we could understand the sort of dependency space, there might be a situation in which you can take the data from one algorithms or one scanner and adjust it 30% up or 30% down and say, okay, with that level of calibration, I would be able to relate numbers that are acquired from different protocols.
That's a very interesting idea. The other podcast in this month's issue relates to MR fingerprinting, and they're actually looking at the signal intensities against what they call a dictionary, which is basically a library of pre-modeled signal patterns from a variety of quantitative MR parameters, and then you make an image by fitting the signal you have into the library that you've gathered. So that's a very interesting idea. Dr. Fletcher, the other thing that you covered that I think has really struck me is the implications for research, particularly multi-center research. And as I was thinking about it in this discussion today, we're hearing a lot about big data, and, the people who are skeptics say there are two things you can say about it. It's big and it's data. But if you have in all these inconsistencies that may or may not be well modeled, I think it could get very tough to understand how do you kind of put this, if you have a well-controlled study and the scanners and this is one thing. But if you're looking at kind of the pooled data from 200,000 people that have undergone a CT scan, it's hard to imagine that you can just assume that it's all going to sort of come out in the wash without accounting for it as a confounder. So, how do you think we should think about multi-center research in this context?
Well, I think it's going to be a lot more complicated. And it's going to involve phantom experiments to make sure that the things that you're testing are reproducible. And because otherwise you are going to have a hot mess, and what you can come out with are only those preserved features across your dose and reconstruction levels.
Right.
And can I go back to another point, which I think is the dose issue that was raised. And I think that, iterative reconstruction, as we know, is the spatial resolution is contrast dependent. And so you can lose low contrast size as you go to very low dose. We've seen that with renal stones clinically and things like that. And it's interesting to me that with the Remy Jardin paper, I struggled with why do they come up with the same answers with a dose reduction and iterative reconstruction, whereas with the liver and kidney things were not. And
I think it's the high versus the low contrast issue.
Yes, and I asked, I asked Norbert Pelk at RSNA about some lung nodules. We had a very low dose study we did with lung nodules, and they were getting smaller. And I asked him why that was, and he says it's because you've taken a high contrast task and made it a low contrast task by doing it at such a low dose. So I think that if someone has metastases, or we're looking for metastases, let's not worry about a 50% dose reduction. We don't need to worry about that. And we can keep it at high dose and still throw on the iterative reconstruction. And we keep it at a high contrast test. But I do see outside studies where people are doing things at such a low dose and they've thrown on the MBIR or the Sapphire, and it's a hot mess.
Mm-hmm. Dr. Nelson, what do we do about research?
I think there's more room for quantitative studies, but this is a real problem. We not only have a lot of data, but we're not sure what to do with it. And the whole other thing that's involved here is not just the attenuation, but you can measure iodine concentrations on material decomposed data sets and water concentrations. And we'd like to think that those are quantitative as well, but we don't really know. So I think we need to stick with the Hansfeld units and kind of figure that out before we start moving to another complete different paradigm.
Well, there's this huge push, and in our journal we see it all the time, for these biomarkers that are image-based biomarkers that are, diagnostic and prognostic. And, the results are actually quite encouraging. But the concern is that as we get more and more use with these techniques and less control over the variability that they're introducing, we're going to sort of undermine the integrity of the biomarkers. And the biomarkers have a process for being qualified as a biomarker, but the qualification may be done on a group of instruments or settings that are not appropriate for the way it's used subsequently in research. So this really seems like something that, our organized professions, societies, and manufacturers need to kind of deal with. I don't think we're going to do, personally, I don't think we'll do ourselves a service if we just go back to being pure morphologists and ignore all the data that's actually embedded in these. But we're not going to do ourselves a service if we start spewing forth numbers that really the error bars are bigger than the effect size.
If I can add to this, essentially, I think talking about quantitative imaging without having an understanding of the size of the error bars becomes meaningless.
Right. Right. Well, on that merry note, Dr. Fletcher, you always have a way of putting a nice spin on things. You want to have the last word?
Well, one thing that this brought to mind is about a year and a half ago, we started, Jeff Fiddler did a study looking at bone strength from CT colonography scans. We've repeated that with enterography. And before we implemented it, we thought, well, we turned KV selection on, we have iterative reconstruction. How are we going to know we're going to get the same numbers? And it really wasn't, I have to say, I thought it would be a big deal. It took about a month.
Okay.
We only scanned people a certain number of ways.
Sure.
We did every kernel, this iterative reconstruction, that iterative reconstruction, gave everything to the company that does this, and they came back with very reproducible numbers. So we have to do the due diligence, but it may not be as terrible as it sounds.
Well, I want to thank you all because I think you've raised a very, very important issue. Obviously, we can't address it at this point, but I think by understanding what the issues are and sort of working together to get a path forward, hopefully we'll be able to have the benefit of the quantitative, reproducible data. So thank you all for participating.
Absolutely.
Thank you.
Thank you.
Thank you.